to the foot. Crazy stuff, right? And so the nerves that came from your foot for sensory, to feel when you touch something, has to come up the leg, all the way up, into the cord, into the vertebral column. Now the difference between vertebral column and vertebral cord is what? What's the difference between vertebral column and cord? The column is the bone structure that's housing the cord. The cord is the extension of the brain, right? So the brain has to extend down as the spinal cord through the center of the column. Just like the Roman columns in front of someone's house, right? If you had to get electric to the lights hanging off of that, it has to go through the center of the column first, right? The wires are the cord going down the center and then out to the light fixture, right? Simple, right? So here's the skull, and we're looking at it from the back now. So we saw from the front, the frontal bone, the coronal suture, sagittal suture, two parietal bones. On the back, we have the occipital bone. And the occipital bone has the lambdoid suture, which sometimes has little tiny bones in it called sutural bones. Did you see that on some of them? It's like a little round bone. There's a suture around it. Or it's called a Wermian bone. If you ever see that term, Wermian bone or sutural bone, it's a bone within a suture. So if you look, this one doesn't have it, but in your book you can look up sutural bone or Wermian bone. Sometimes there's a difference in the person's skull. When it formed a little island around the occipital bone and forms another little suture around it, and that's called a Wermian bone. It's just a bone within a suture. Okay? So here's the occipital bone with the external occipital protuberance, the EOP, which forms an attachment for the nuchal ligament from the muscles and the ligaments in the back of your neck. And when you go to the doctor and you have a fever, one of the first things he'll do, or the first thing in the doctor's exam, puts his hands on his forehead and grabs the back of your neck. I think I demonstrated that the first day of class, right? And he's pinching the back of your neck. You know, like if you're a patient, if you're my patient and I'm a medical doctor, because we see a lot of infections, if you're a medical doctor and you sit down in the chair, I want to make sure I know if there's any meningitis in my office. So I'm just feeling the back. He's not being friendly with you. He's feeling your temperature and feeling your nuchal rigidity. Feeling for nuchal rigidity. It's a ligament called the nuchal ligament that helps to connect all the muscles in the back. If that becomes rigid and hard, and you have a high fever, there's a chance that this person possibly could have meningitis. It's a quick scan out and rule out meningitis patients, so you know to isolate that person, and let's do further tests.
It's called
nuchal, N-U-C-H-A-L. And it's called the nuchal ligament that goes all the way up.
You said it has to be, if it's hard.
If it's rigid and you have a fever, it's a scan. It's not an end-all diagnosis that there's a possibility we have to take another step to rule out anything further. So they always, if you notice, you go to the doctor, he does that. It's a habit. It's what they do. First thing, palpate the head, you feel for temperature and feel for nuchal rigidity, and especially if they have a fever. It's a very quick scan. I mean, you want to know right away if someone has a serious meningitis. So now, the skull sits on top of here and has to attach to the vertebrae. Muscles, ligaments are attaching. We talked about that nuchal ligament. There's many ligaments. You have the foramen magnum, which is the largest foramen in the skull, not the largest foramen in the body. We're going to learn about one down here later, the smooth obturator. And this is the largest foramen in the skull, which is where the brainstem passes through. As soon as it passes through the foramen magnum, it's now called spinal cord. Above it, it's medulla. Just below is called spinal cord. Recently, Dr. Damadian did research with one of my colleagues and found out that patients with MS have interference with cerebral spinal flow due to misalignment at C1, and when you adjust them, they see the cerebral spinal flow change. Very big finding. And helping the symptoms of patients with MS is a very big. They just did a seminar last week. Dr. Damadian did one. It's exciting stuff. So here's the sprain extending its spinal cord down through the vertebral canal. Inside every vertebrae, in the center is something called the vertebral canal. We're going to go over that. And that's where the spinal cord comes through. We'll talk about that later. But let's talk about this occipital bone again. EOP, lambdoid suture. Mastoid process is actually on the temporal bone because the suture comes down and separates it there. And then you have your foramen magnum, and then you have these occipital condyles. The occipital condyles are going to sit on top of what? Atlas. They call it Atlas, C1, because it's like the mythical character Atlas holding up the world. And even the hands are shaped similar to the joint surface of the atlas on the top. And so the skull sits right on top of that. The two occipital condyles are sitting right on top of that. Imagine a 10-pound weight sitting on those two little tiny joints of this 3-ounce bone. Right? Remarkable. And if it shifts off center, it can affect things, right? So muscles tone changes, everything changes. So what happens here, our body has this thing called a righting reflex. It always wants to keep the head neutral with the earth, not like this, right? If you go around a Ferris wheel, you're always trying to turn your head and then get neutral, right? Well, the same thing happens. If there was to be a misalignment here, your body would try to correct. It wouldn't walk around like this, so it would shift your whole posture to get in front of this. So what happens is you have a mechanism here. On the joint surface, there are more nerves here for position in space than anywhere else in the body. They're called mechanoreceptors, M-E-C-H-A-N-O, receptors, mechanoreceptors. Mechanoreceptors are specialized nerve receptors like you saw in the skin. Remember when you studied the integumentary system, Meissner's corpuscles, right? Remember the touch receptors, Pacinian corpuscles, lamellated corpuscles, Ruffini's corpuscles. These are nerve receptors that pick up information of movement, any kind of movement. And remember, we learned about different types of receptors and ion channels. Remember that? So they have mechanically gated ion channels on those nerve receptors. So anytime there's a mechanical movement, it sends a message to the brain. It tells you where you are in space. If everybody just closed their eyes right now for a moment and put your hand out, don't hit your neighbor next to you, knock him out, and touch your nose with your finger. How did you do that with your eyes closed? Because you have mechanoreceptors in your joints and your muscles and your tendons telling you where you are in space. You see that?
So it's a special...
So you know where, yeah, mechanoreceptors are all over your body, but this is the highest concentration of any joint in the body because of the righting reflex. So what happens is, guys, is that this bone, we're going to learn about the C1 and the C2, they're the only atypical vertebrae in the spine. It's totally different. The whole anatomy and physiology of this area is unique to the rest of the spine. It's not something that you just fluff over. There's a lot of differences here. And what happens is, when this misaligns, and it can misalign because there's no one specific muscle that can pull it back into place. It's groups of muscles that are holding everything together. So if this does get misaligned, there's no bony locks on this. It's the only vertebrae in the spine like that. There's no bony locks. If that should misalign, it could potentially cause a serious damage and cut off your cord supply. That would be bad. You'd be dead in a second. So your body protects itself and shifts its posture all over the place. All right, so that's your occipital condyles. It has the highest concentration of what? Mechanoreceptors. The mandibular fossa of the temporal bone has the highest concentration of what? Nociceptor. Now let's see how this is in the jungle. Right? I was born in Africa, so I always try to think if I was in the jungle and I had to survive at night, right? How would I survive? Well, you have hearing right there, right? You have the most pain-sensitive joint right there, and you have the most mechanically sensitive joint right in that spot. Why? Because this is the brainstem. Right there is the brainstem. And if anything damaged the brainstem, you're done. You don't breathe, your heart doesn't work, everything shuts off. You know, how do they kill people? If they had to put somebody to death, cut off the neck, right? Hang them. Well, the hanging doesn't choke you, you know that, right? The hanging fractures C2 and it severs the spinal cord at that level. And that's what kills the person.
I saw the jaguars kill
Go to the throat and the neck, yeah. Well, you know, if you know, Marie Antoinette, let them eat cake, cut off the heads, right? So the quickest way to die is that, and it's the most humane way to die for animals, like we have halal meat and kosher meat. That's how they kill the animal. It's the most humane because it's a fast way of death. And being a former Marine and a sniper, the best shot is right there too. But if something was to come up against you, like a twig or a stick, and you're laying and you were moving into it, you'd hear it, first of all, and you'd sense it because it's so sensitive there, right? And any kind of pressure, you acknowledge it. You know, I was watching the UFC fight, and the guy got hit right at the atlas. He wasn't ready for it, and it got hit like behind his ear right there, and the guy went down. He couldn't get up for a while. He said the whole room was shifted. A very dangerous area here, and it's very vital. So look at how the atlas sits there between the mastoid, the style. Look at that. There's not much room there, right? You can barely see. So when I adjust it, I use an instrument. It's a stainless steel instrument. It has a tip that just touches the skin over that. And the patient's laying on the side, and the bone gets shifted into position very gently. Pretty amazing stuff. So now let's go back to the rest of the skull here. We saw the frontal, parietals, occipital, temporal bone is on the side. There's something called a squamous suture, which you could barely see on this. Remember we talked about that shape of squamous, and I had mentioned it looks like a squamous suture, right? And then coming off the temporal bone, you have this other thing coming here. What is this?
Is that the
Neuromatic.
process?
Well, okay, sometimes we just call it the bucket handle, right? That's what the Predator would put it on his belt, you know, all those skulls he got in that movie, The Predator. If you ever saw the movie The Predator, he was hunting people and putting them on his belt like that. But it's called the bucket handle, which is a very susceptible place to fracture, isn't it? Doesn't it look like it's just waiting to be fractured? And what happens is you have a bony process coming off the temporal bone that meets a bony process coming off the zygomatic bone, the cheekbone. So this is your zygomatic bone, and then it has a process coming out. And if you look, I'm going to do a naughty. I'm going to draw right in this suture. There's actually a little tiny joint articulation between the two. See that? It's scored and ready to be broken, right? If you had to chop something, you score it a little bit and just chop it. Well, look, you have the zygomatic bone coming here and the temporal bone coming here. So it's just like New York and New Jersey. You have a border of one and the border of the other, right? So this is the zygomatic. This is the temporal bone. This part of the zygomatic bone, if you're walking on the zygomatic side towards the temporal bone, is the temporal process of the zygomatic bone.
Whoa.
You get it? Okay, so look, if you're in New York and you're heading to New Jersey, and you didn't quite get to New Jersey, and you're standing there, and the border's right there, right? Let's say this was New York, and you're standing on this side of the border of New Jersey. You're on the New York border of New Jersey, right? Okay?
Okay.
So, or you could say, I'm sorry, you're on the Jersey border. I'm sorry, you're on the Jersey border of New York because you're in New York, right? And if you're on this side, and this was Jersey, you're standing on the New York border of Jersey, right? That's easy to remember, right? If you're standing in the state, you're in that state, and you're on the opposite state's border, right? Right, yeah, in the U.S., you're on the U.S. side of Canada, right? You're on the zygomatic side of temporal bone. So you have the temporal process of the zygomatic bone, just like the New Jersey border of New York, right? Or the Canadian border of U.S. And then if you're on this side, you're on the zygomatic process of the temporal bone. You get it? Together they form the zygomatic arch. Together they form the zygomatic arch. It's the most commonly fractured place in the face. If someone's going to get a facial fracture, 9 out of 10 times that's where it's going to happen. It's the most commonly fractured location of the face. So if you're a nurse and someone gets a blow to the face and it's swelling around this area, are you not going to have them get an x-ray? Of course you're going to make sure that they see the doctor and get an x-ray, right? Because it's a chance it could be fractured, and if it doesn't heal right, that could be a problem, right?
It feels so thick though.
Yeah, well, it feels thick, but it's easily fractured. Don't challenge anybody. Okay, so that's your view from the side, right? And you have your mandible coming in, the mandibular fossa, right? And I don't get too crazy on the mandible. You have the mental foramen here, you have the arch here, and you have the coronoid process. I don't really ask that too much. I'm more interested in clinically the temporal process of the mastoid, or the mandibular condyles, and the mandibular fossa on this, and the mental foramen. Looking at it from the front, and you have a beautiful image in your book. It's color-coded for the orbits, which is nice to use that. And studying the orbit alone helps you to go light years ahead in understanding the skull. If you just try to figure out what bone is what and then go in and dig it out, it's more exciting like that. So you have your frontal bone still up here, 2 nasal bones, your zygomatic bone on either side, and then deep